Today we're diving into a place where life and death decisions are made every single minute, the intensive care unit. For a first responder, this is often the handover point, but for a family, it's where everything just stops. We're going to explore what happens when someone can't speak for themselves and how this incredible mix of technology, law, and just raw human emotion comes together to try and find the right path forward.
It always starts in a single critical moment. Someone is rushed in, they're unconscious, unable to tell their story. This is where our journey begins, right at that point where the heroic, life-saving actions of the first responders on the scene transition into the complex, long-term decisions of the ICU team. The baton is passed.
It's a question nobody ever wants to face, right? But it happens every single day in ICUs all over the world. When the patient can't be their own advocate, this whole intricate dance of medical and ethical decision-making has to kick off in an instant. And the very first step? Figuring out what on earth is going on.
So, the first job for the team is to become a detective. They have to decode the body's signals to figure out what's gone wrong. And the clock is ticking. They need a crystal clear picture of the problem, and they need it fast if there's any chance of turning things around.
Okay, so a physical exam is always that crucial first step. Doctors are looking for those classic signs like mottled skin or cold hands and feet. That can tell them a patient's in shock. But here's the problem. It often can't tell them why. It's kind of like seeing the smoke but having no idea where the fire is. And that's exactly why modern ICUs rely on advanced hemodynamic monitoring to get real-time, hard data on how the heart is pumping and where blood is actually flowing.
And here's why that technology is so critical. Get this. Studies show that a physical exam alone is only about 56% accurate in predicting what's really happening with a patient's hemodynamics. 56%. That's basically a coin flip when someone's life is on the line. So yeah, this tech isn't some fancy luxury. It's an absolute necessity to get the diagnosis right and start the right treatment immediately.
But once that immediate medical fire is being fought, a whole different question starts to surface. It's a huge shift from what we can do for this person to what this person would actually want us to do. And this is where the world of medicine collides with the world of law. You might think that patients have always had the final say, but that's actually a pretty recent development. It was a series of landmark legal cases that really shaped how we think about this stuff today. It kind of kicked off in 1976 with the Karen Quinlan case, which established the right to refuse treatment. Then in the 80s, you started seeing things like the Illinois Living Will Act, creating the first real legal tools for people to write down their wishes. The whole thing really came to a head in 1990 with the Supreme Court's Cruzan decision, which said loud and clear, you need clear and convincing evidence of what a patient would have wanted.
And this is exactly what those laws were all about. A document like a living will was literally designed to be the patient's voice when they can't speak for themselves anymore. It represents this massive, fundamental shift away from a doctor knows best model to one that truly tries to honor an individual's own values.
So how do doctors even decide what treatments to offer in the first place? Well, there's a legal standard for that, called the Bolam test. Basically, it means a clinician uses their professional judgment to create a sort of menu of reasonable treatment options. Then, that menu is presented to the patient or whoever is making decisions for them. It's a way to make sure all the options on the table are medically sound before any personal choices are made.
But here's where we hit one of the toughest, most painful challenges in critical care today. In these really high-profile, emotional cases, you have a family that wants to share their story and fight for their loved one, but that can sometimes clash with the hospital's duty to protect the privacy and safety of its staff.
And what's so fascinating is how courts are trying to navigate this. Recent cases in the UK, like Abazi and Tiramalish, have had to perform this incredible balancing act between two fundamental human rights. On one hand, you have Article 8, which protects a doctor or nurse's right to privacy and from harassment. On the other, you have Article 10, protecting a family's right to freedom of expression. These two can be in direct conflict, and the courts have to somehow find a path that honors both. And in a really important judgment, the Supreme Court basically said, look, you can't just shut down these difficult conversations. ICU staff, in the context of their jobs, are public figures, and how patients are cared for is absolutely a matter of public interest. Now, that doesn't mean it's open season for harassment, but it does mean that talking about these tough cases is vital for a healthcare system that's open and transparent. So as all these ethical debates get more and more complex, the day-to-day work in the ICU is also getting more technologically complex. To deal with the absolute flood of data and the pretty crushing workload, hospitals are starting to turn to an incredibly powerful new tool, artificial intelligence.
And I want to be clear, This is not science fiction. It's happening right now. Just look at these examples. Hospitals are using AI for all sorts of things, from automatically handling documentation and transcribing notes, to even deploying little therapeutic robots to help reduce a patient's anxiety. The whole goal is pretty simple. Let the machines handle the routine stuff so the humans can focus on what they do best, caring for patients.
At Apollo hospitals in India, for instance, AI-assisted documentation is giving clinicians back 2 to 3 hours of their time every single day. Just stop and think about what that really means. That's more time to sit and talk with a worried family, more time to double-check a complex diagnosis, more time to just be there at the patient's bedside.
And what about the impact on the caregivers themselves? A pilot program at Mass General Brigham that used AI scribes saw a staggering 40% drop in physician burnout. By lifting some of that administrative weight, AI is actually helping to heal the healers. This chart just visualizes that impact so clearly. We're seeing real, meaningful reductions in after-hours work and burnout. This isn't just about making things more efficient, it's about making critical care a sustainable career for the amazing people we all depend on. So with all this incredible technology and all this legal complexity, how do we make absolutely sure the patient's own voice doesn't just get lost in all the noise? Well, the answer seems to be a shift away from static pieces of paper and towards something much more human. The old way of thinking, where you fill out a living will once, stick it in a drawer, and forget about it, that's really starting to fade. The new approach is what people are calling a communications model. It's built on the idea that a person's wishes might actually change over time. It puts the focus on having ongoing conversations about your values, your goals, and what quality of life truly means to you. This is basically the modern roadmap for making sure your wishes are known. It all starts with you, just reflecting on your own values. Then, you choose someone you trust completely to be your healthcare proxy, the person who can speak for you. But honestly, the most important step is number 3, talk. Have those open, sometimes difficult, but totally necessary conversations with your proxy, your family, and your doctors. The document? Well, that's just the final step, a record of those crucial conversations. Ultimately, it seems like the more powerful medicine becomes, the more responsibility we have to direct that power. AI and advanced monitoring can keep a body going longer than ever before. But it's the very human conversations that we have right now that will make sure our own values are guiding our care when it matters most. So the single biggest question this all leads us with is a simple one. Have you had that conversation?